Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
All right, what's up, guys? It's Erin with Wild Health, one of our premium docs. Excited to be back with Dr. Kyle Gillett today. So I'm pretty stoked to talk to Kyle today. He is dual board certified in family and obesity medicine and runs Gillett Health. Is that right?
Yes.
Nice, nice. So he focuses on a number of different things, but a topic he talks largely on is hormone optimization, metabolic health, fertility, longevity, you name it. And I'm sure he knows all your basic primary care info as well. So he really combines kind of your classic evidence-based medicine with looking at practical lifestyle strategies as well. He's been a guest on numerous podcasts you may have heard of, Huberman Lab being one of them, Muscle Intelligence Podcast, School of Greatness, etc. And he lives in Kansas. He is married and has 3 kiddos. So what did I miss, Kyle?
Yeah, thank you for having me. I also have the Gillett Health podcast that's on all platforms.
Right on. Yes. So check that out because you do a lot of a deeper dive into probably most of the things that we will just barely touch on today. So if anybody wants to learn more, you can learn from him there. So really cool. We just were talking about this briefly, but Kyle and I have a little bit in common. I went to undergrad at the University of Kansas and you went to med school there, right?
Yes.
Nice. So fellow Jayhawks, you gotta love that. Um, it's just starting to be basketball season, so I don't know how big of a basketball fan you are, but it's an exciting time of year for the Jayhawk family. So I'm excited that the real sport is now starting, which my husband probably would not agree with me on. So let's talk a little bit about your background first. So you clearly don't practice in just a traditional primary care way, right? You run this podcast, you teach courses on hormones, right?
Yeah. And the reason I went into health optimization and hormones specifically is largely just related to supply and demand. They're extremely important and they can help a lot of people. And there is a huge demand for high quality care, but there's not a very large supply of physicians that are able to provide that care.
Mm-hmm.
And many people that have no science or health background whatsoever try to, and some of them can do a pretty good job. But, growing up, I saw a dad who also went to KU Med, who's also kind of like a full scope family doctor. He grew this faith-based clinic to almost 100 providers, and people pray for their patients, which I love, and try to
Yeah.
care for them holistically. But it got bought by a big hospital system, and basically it fell apart like pretty much everything else does that gets bought up from a mega system like that, which is very unfortunate. But I figured I'd practice with him and provide very good concierge medicine. So I knew that I wanted to do medicine since I was, 11 or 12, very young. And being homeschooled with my brothers helped a lot. One's a dentist and one's an engineer. But I figured I would want to work with dad and, take care of patients in that way. And as soon as I got out, I just knew that this wasn't it. So I was friends with Derek, who has the More Plates, More Dates YouTube channel. I helped start Merrick Health with him. I was the medical director for their first year. And I also ran the functional medicine clinic that my dad's clinic had. And then after that, that's when I started Gillett Health. Some advisors and mentors told me that would be the thing to do. But I was actually very happy working within systems if I could, but it was just not for the best quality of care of the patient itself.
You didn't
So
find a system that aligned with the way you wanted to practice, it sounds like.
neither the big alternative medicine practices nor the big conventional medicine practices had it.
Yeah, I relate to that for sure. Very similar. I used to have my own practice and very similar reasoning. It's not that I wanted to run a business necessarily or wanted to own everything myself, but it just found that was the way to, until I started working with Wild Health, that was the way to treat patients the way I wanted to treat patients. So totally relate. So tell me a little bit more about the education piece then. You obviously do a lot of educating, both in formal courses, which I believe gives CME credits for physicians, correct? As well as, things like this, your own podcast, etc. My guess is you have a passion on education. Is that also because there's this like, is this altruistic part of you? Like there's a lack of doctors that know how to do this well and you want to help, share that, or do you just really like educating?
Yeah. So eventually, I'd love to be more and more involved in education. I do a lot of CME events every year. And the main reason why is I would like to balance the good things of conventional medicine and functional medicine, and also be able to talk about the bad things. For example, 5 years ago, when I started um, Derek's clinic with him, I used to talk about all these cases. I would say we were some of the very first to microdose GLP-1s. We were using peptides. And I was talking about this on, Mark Bell's podcast probably 4 years ago and with Greg Doucette on his YouTube channel. And I was the first repeat guest on Huberman's podcast as well. He's actually who told me to start my podcast and call it Gillett Health. But I've seen the pendulum swing to where now I get on Instagram and there's people who have no idea what they're doing. And they say, take these hormones, take these research chemical peptides, use my code 15%. Here's some shirtless pictures of me. And being in shape is great. I'm in good shape. Go to my Instagram if you want to see my DEXA scan. I offered $5,000 to any doctor that had better metrics with their DEXA scan than mine.
Amazing.
Nobody's won the $5,000 yet. Somebody will probably hear it on this podcast and then go
We
in.
do have a lot of
But
fit physicians that listen to this podcast. They
yeah,
might
so
try to come for you, Cal.
yeah, so go check that out. Happy to give the prize away. But the point being is, there's a difference between being very knowledgeable about helping patients. You're basically a coach because at the end of the day, patient autonomy is so important. I want them to know all the upsides and the downsides. So I spoke at this longevity conference actually a month ago, and people came up to me and said they thought that I was the anti-peptide guy. I was like, well, no, I am the pro-peptide guy and the pro-hormone, pro-HRT guy. I just want to give people the tools to develop a balanced approach to their health. They make an informed decision. And I think it's the way for everything. Vaccines, medications, supplements, peptides, at the end of the day, it's just pharmacology, and you need to understand the upsides and the downsides.
Yeah, for sure. It's not like there's no free lunch, right? Like you can't just take a peptide and all your problems are going to go away if you're not doing the basic lifestyle stuff, it can be
Mhm.
supplements, meds, like you said, like they can all be a lever to pull, especially if it's an adjunct to the appropriate lifestyle shifts, right? Yeah, I think we're pretty aligned there with how we practice and how you do. It sounds like from what I've heard. Well, let's dive into it. So, on that note, we test really broad labs in all our patients, right? So we are going to, I mean, comparatively to probably most primary clinics anyway, and we get a lot of people. They're really fit. They're kind of quote unquote doing all the right things. May or may not be, but they're trying, right? We don't get a ton of like standard American lifestyle, patients rolling in the door just because of the bias that if they're looking for us and they're willing to pay and look at this data, they're probably doing some things right. Um, and there's a good chunk of those people that have, like, at least for the male population, testosterone levels lower than what they would like, and maybe lower than what would be considered optimal. So I have a few questions about this. The first I'd like to dive into is your thoughts on, hasn't this reference range of normal changed over time? That data is kind of hard to extrapolate if I'm understanding it correctly, but is that safe to say that the normal level of like what a true deficit is, has that definition has changed over time, right?
Yeah, testosterone levels have definitely gone down. I actually very recently filmed a podcast specifically on this, and one of them was published by my friend Dr. Jake Fantis, who is also went to he's a faculty at KU. He didn't go there, But he's local. He's a reproductive infertility urologist. And basically, testosterone levels have decreased, but there are several reference ranges. So some reference ranges that people might be familiar with is just the LabCorp reference range or one of the other lab companies. But generally, the accepted level of normal before you quote unquote need replacement, the arbitrary line is if you're 299 nanograms per deciliter of total testosterone, then you need replacement. And then if you're 301, then apparently you do not. And of course, I'm being sarcastic because um, it depends on your androgen receptor sensitivity and density. So basically, you have to receive testosterone, and there's genetic differences. There's also differences based off of what has happened through your life, both nature and nurture. And there's also a difference. This is the big takeaway that people should know, and they might already know. Um, in SHBG, which is sex hormone binding globulin, this binds up all your androgens and estrogens. And you can actually calculate a free androgen index. James O'Hara, my podcast co-host, has a free calculator on his website. But yeah, you can calculate your FAI, your free androgen index, and that will give you a good idea of how many androgens are actually working in your body. SHBG also protects testosterone from metabolism. So the number one reason for decreasing
I didn't know that.
testosterone, yeah, is probably not microplastics. It is likely that SHBGs are decreasing because when insulin, people have heard of insulin resistance. When insulin binds the insulin receptor in the liver, it directly downregulates production of SHBG, which leads to faster metabolism of all androgens, including testosterone, and actually estrogen to some degree as well.
Interesting. So, yeah, we definitely want to look at the full picture when you're getting your testosterone checked. You want your total, your free, your SHBG, and you need that estradiol ratio as well, right? To really have an effective picture. Um, let's talk about eh, well, I have some questions about, I think, some of the nuance you just brought up about why maybe some men feel fine at 500 and some men feel low at 700. I think it's probably to do with some of the receptors and some of the other stuff you just mentioned. So maybe we dive into that when we're talking a little bit about TRT. But since you brought up SHBG, would you mind going through the difference primarily in the actions of total T versus free T? Like these don't entirely equate to the same physiologic meaning, right? I mean, free T is gonna if you have a really low free T, you're gonna see a different outcome than if your total T is really low, right? There's some breakdown here, isn't there?
Yeah, so it's a great question. For example, a lot of the correlation studies look at free testosterone, total testosterone, and SHBG differently. So if you have a very high free testosterone, then there's more acting on tissues. Then you might have, for example, um, continued higher levels of muscle mass accrual, but you're not bound to the protein of SHBG, which can help cross some barriers. So if you're looking at the neurologic aspects of testosterone, then you might need more testosterone bound SHBG. And of course, men have kind of like a people, and this is a little bit of benevolent clickbait, but people say that men have a cycle as well, like a hormone cycle, because it's high in the morning, low in the evening. And it tends to be if you're older, you have less fluctuation. If you're younger, you have very high levels in the morning, very low levels in the evening. This is mostly related to SHBG. So you're still producing testosterone at relatively the same time. But if you have an SHBG of, say, 20, then you're going to metabolize a lot. And by the evening, a lot of it's going to be gone. And then if you have an SHBG of 60, which most older men do, then you're going to have a low free testosterone. You might have more body composition issues. And also, um, your peak is not going to be as high in the morning, but you're still going to have a relatively higher level in the evening. So the gold standard of 2 to 3 fasted morning testosterone levels doesn't give us the whole picture. Eventually, we'll just put on a CGM for testosterone like we have for glucose, and that'll be quite nice, and for LH as well. But um, yeah, a good takeaway is if you feel like your testosterone is not as high as it might be, or maybe you feel like it's higher, maybe it's clinically low, but you're not feeling like it, it's likely related to either the diurnal rhythm, the circadian rhythm of testosterone, or it's related to your SHBG. And then I also mentioned androgen receptor density and sensitivity. So again, Dr. Fantis makes the analogy that if you come off of a relatively high dose of Adderall back to a normal dose of Adderall, that normally you'd feel great. Your receptors are not very sensitive to it. And regardless of what people think of that, last time I said it, I know we got several comments on that video. That's not a good analogy because like you don't need that and you need testosterone. Okay, I'm not saying anything bad or good about whatever. It's just an analogy. People understand that the receptors can lose temporary sensitivity, and really that's density. So after you've been on testosterone replacement, whether you're a male or a female, actually, you usually mentally get sensitized to it.
Probably another reason why if you stop TRT suddenly, I mean, your levels, like, ultimately, if you're still in an age where you're gonna produce a good amount of
Mhm.
testosterone, those will come back up to your baseline eventually with
Mhm.
if you're doing lifestyle support, etcetera, but initially, there's gonna be a drop because of that receptor change, yeah?
Yeah, and even if there's not a drop in testosterone, most bodybuilders who come off their steroid cycle, they go back on 200 milligrams of testosterone per week, which is a pretty high dose of injectable testosterone. Most of them feel low T, even on 200 milligrams of testosterone cypionate or enanthate, and that's why.
Yeah, because of that change, yeah, that makes total
Mhm.
sense. Rad. So thanks for explaining that. I think, I mean, it sounds like the take home, you don't want to both free T and total T have their purpose, and you don't want too high or too low sex hormone binding globulin is what I'm hearing you say.
Yeah, and the way I explain it is total testosterone gives most of the mental and cognitive benefits, and free testosterone gives most of the body composition and metabolic benefits. But you don't want too low of a free T, and you don't want too low of an SHBG. Higher SHBG is good. In fact, if people have done different genetic tests, the gene, quote unquote, for high testosterone is actually not related to testosterone production. It's related to SHBG production. So
Because
the
it's
liver,
protecting against that metabolism.
yeah, exactly.
Yeah.
So, yeah, just the way I explain it best is you don't want low SHBG and you don't want low total T. But if you have a very high SHBG and adequately high total testosterone to overwhelm it, I think that is fantastic.
And that ratio, if your total T is adequately high, that ratio of free T should still be okay, even with a high SHBG, right?
Yes. And another rule of thumb is if you double or triple your free testosterone, that's about what your estradiol should be as a male.
Yeah, okay. Well, you brought estradiol up, and we just talked about ratios. So, might as well, this is a little bit of an aside because I think the low T and TRT discussion will be a little bit longer. I think I know your thoughts on aromatase inhibitors, but would you mind sharing them?
Yeah, for most people of normal body composition, aromatase inhibitors are not necessary. Now, coming off of it, there is an aromatase inhibitor withdrawal syndrome, so it can take a while to get accustomed to tolerating normal estradiol. But yeah, the other thing is it's just important to know an accurate estradiol. So the cheap estradiol test, which is called an immunoassay, like an ECLIA, that is
Mhm.
going to usually overestimate, but it's not very accurate under 50 picograms per milliliter. So most males will want an LCMS or an equilibrium dialysis or ultrafiltration assay, which is generally called a sensitive estradiol, which is a little bit more money. It's a more expensive, more specific test because you're not just doing a luminescence, but it's a lot more accurate and it doesn't overestimate your estradiol as much. Now, if you're symptomatic, like let's say you have itchy sensitive nipples or gynecomastia or tearful episodes very frequently, then certainly a temporary aromatase inhibitor or even something like raloxifene, which is a selective blocker and activator, those things can be reasonable. And I'm fine with the natural options as well. You know, look at your gut because your estrogen, every time it passes through your system, about half of it goes through your gut and then about half of that's reabsorbed. So your gut is extremely important for estrogen metabolism via a process called glucuronidation. And then there's also natural aromatase inhibitors that people can do as well, like D-chiroinositol.
Yeah, for sure, and it's handed out pretty frequently, when TRT is given, correct? I mean,
Mhm.
historically, it's kind of a 1-2, when people get started on one. I mean, I don't mean to oversimplify it or call anyone out, but that's kind of been for a while, the way things have typically been done, right?
Yeah, a rule of thumb is if you're under 35% body fat as a male, you're probably not going to need a aromatase inhibitor, so they shouldn't be handed out automatically.
Yeah, and so for people listening, I mean, your fat tissues are gonna contain this enzyme that is going to, expedite this conversion of testosterone to estradiol, right? So you're gonna
Mhm.
be more likely to convert your testosterone over. Do you also see this more when men are super therapeutic for their T levels? They start converting it to estrogen more readily,
Yes, but
or
generally
or
they're not
just by nature of
symptomatic.
the ratios?
Yeah, the ratios should be about the same, even if they're on supraphysiologic doses. But they they shouldn't be symptomatic unless they have a different reason that they're very estrogenic. For example, a lot of people who have kind of self-prescribed TRT or took some other androgens when they were younger. Um, if you've been on aromatase inhibitors in the past, you're more likely to be sensitive to estrogen, like higher estrogen levels in the future.
Mhm, mhm. That makes sense. I actually didn't know that if you'd taken them in the past. Super interesting. Okay.
One
Cool.
example, really quick, is
Yeah.
if there's a female after menopause and her menopause was 20 years ago or even 10 years ago, she's going to be extremely sensitive to estrogen if you start. So you have to be very careful with dosing. And it's just the same way with men. So if men have had very high estrogen levels, you also have to be very sensitive with dosing because whenever you're dosing testosterone, you're dosing estrogen as well.
Again, probably because of that receptor sensitivity, right? Would be my guess. So, or at least in part, if
Yeah,
you've been off of
yeah,
things for a while.
yeah. Not going into too much detail, estrogen receptors are much more complicated than androgen receptors. So testosterone, DHT, every androgen only binds one receptor we know of. It comes from your mother. It's on the X chromosome. So females have two X chromosomes and two androgen receptors. And actually in PCOS and such, there's a lot of mosaicism where certain sensitive androgen receptors are expressed in areas like the skin or the scalp, but and even the ovaries. With estrogen receptors, there's a whole bunch of them: ERA, ERB, the membrane estrogen receptor, ERRA, ERRB. For example, SLUPP332 binds one of the estrogen-related receptors. So there's a whole host of estrogen receptors, which of course have different concentrations in various tissues. So that's one reason why estrogen is a bit more complicated. But a good clinical takeaway is most people don't need aromatase inhibitors at physiologic doses or physiologic ranges, really, um, and their normal body fats.
And you should probably thinking about targeting fat loss more aggressively in people if their estrogen ratios are too high anyway.
Yep. It fixes a lot of
Cool.
things. That's true.
Yeah, yeah, for sure. Rod, so let's talk about low T. So one question I want to ask, and we kind of touched on this, is it seems super variable from man to man in my anecdotal experience. I know you may talk to a specialist and they may say, well, it's normal. And normal could mean anything from the very low end of the range to the very high end of the range, right? We don't really practice that way typically. We have more narrow optimal ranges for most things, but testosterone is one of those things that some men feel fine at a certain range, and other men of a similar age, in my experience, feel super low. And I don't know. I think there's a and some of my patients will admit that they're like, look, I've optimized everything else. I do everything right. Like I want to see how I feel at a higher number, and it might just be about the number for them. But some men really are experiencing symptoms that are pretty consistent with what you would consider to be more classic low T symptoms, at kind of a normal, like lower end of normal range. So help us understand that a little bit if you don't mind. Like why is that variation exist?
Yeah. So this is 100% true. There is a lot of individual variability to how they feel at a testosterone level, whether it is endogenous, so naturally produced, or replacement, exogenous. And we mentioned receptor density and sensitivity as two issues, but I'll mention a very extreme case is androgen insensitivity syndrome, AIS. And there's actually lots of famous people who are, uh, you know, pro- supposedly AIS. So people can go Google the conspiracy theories or whatnot if they want. But it's basically where your XY chromosome, but genetically you have such insensitive androgen receptors, usually due to a huge number of CAG repeats, or where the androgen receptor on your X chromosome that you got from your mother, just like does it does not bind testosterone or DHT or any other androgens well, and you actually develop as a female. So you phenotypically look like a female. You have testes, but they're inside the body. So this is obviously extreme. But there's anything from that, and then slightly more mild is Kennedy's disease, which is spinal bulbar muscular atrophy, where you have a lot of CAG repeats. This is like trinucleotide repeats. If people are familiar with Huntington's disease or Fragile X syndrome, this is the same, but just with the androgen receptor, with testosterone. And then you can be extremely sensitive. So actually, people from different countries and people from different backgrounds are more or less likely to be very sensitive to testosterone via the androgen receptor. And there's a lot of associations like decreased or increased sexual jealousy, decreased or increased likelihood of developing schizophrenia, decreased or increased likelihood of developing male pattern baldness, prostate cancer, etc. So I've done a lot of podcasts on this, so I don't want to get like too jargony, but basically that's answering a lot of the question. That being said, there are people that you think are androgen insensitive and they have all the low T symptoms, and you start them on a therapeutic trial of replacement. And one important thing to know is you can get back what you had previously. So let's say somebody has a testosterone level of 400, you replace them up to 900 and they don't feel significantly better. That could be other things like dopaminergic input. It could be, mental or psychiatric symptoms as well. So there could be a lot of things. It could be their prolactin's very high. So obviously get a good lab panel and check all of it. So there are other reasons other than androgen sensitivity for the variation in response.
Yeah. And I guess maybe I should put an asterisk. I mean, there's obviously central causes of pretty significant hypogonadism that we're not even mentioning here that are a little bit, they're less common. They're very significant. They need to be treated and managed and diagnosed, right? So, yes, check your FSH, your LH, your prolactins, like know what's going on in the brain and make sure that the body's getting the signals to produce testosterone appropriately, right? But I would say more often than not, the average person we're talking about is, those things are pretty normal and then there may be some downstream issue, whether they're sleeping poorly or whether it's, their receptor sensitivity, kind of how they're wired, so to speak, stress levels, cortisol levels, insulin resistance, et cetera, et cetera, et cetera. So like a number of things that can play a role there. Interesting. Okay, so let's talk about lifestyle for low T or suboptimal T. Obviously, that range is going to be different for different people. What are the big drivers that you see move the needle the most? I know in my clinic, what I see matter the most that are, if you had to name the ones that you see the highest ROI for, what would it be?
Yeah, you've mentioned several of them. Number one would be metabolic syndrome. So insulin resistance and high glucoses often comes with high body fat percentage, high insulin, low SHBG, low testosterone. The second one would be sleep. Again, as you mentioned, you can feel terrible and um, you will likely have better testosterone production if your sleep is better. But sleep apnea is also a common cause of clinically low testosterone. That's something that is checked often, even if you went to a very conventional medicine doctor. If you had symptoms, low testosterone, they would make sure you don't have sleep apnea. Um, then there's other things like overconsumption of, um, sugar sweetened foods, even without metabolic syndrome, that can affect it. Another thing is um, overconsumption of screens. So you're just like chronically online, you're always inside, you're not outside. I guess that's a little bit more controversial, but I think that that's one of the reasons why testosterone is declining. And then an unnatural environment as well. So, drinking out of plastic cups and plastic everything all the time rather than something that's more natural. I think it does make a difference. And I think there's pretty compelling evidence that, we have lots of microplastics. So doing things like sauna, sweating, just I do enough cardio that I actually very rarely sauna. But yeah, just like sweating and having a very healthy gut, I think is a step to develop a adequately high testosterone level. And then lastly, there's kind of like the social, emotional, and even spiritual / metaphysical component. Um, and this is harder to prove causal link, but if someone, I think it is possible for someone to be very depressed or sad or even undergoing bereavement. And through some feedback mechanisms, testosterone may decrease. I saw one study that noted a link between if you live in the same bedroom as your spouse as they're breastfeeding a baby that's awake often at night, then your prolactin also goes up and your testosterone usually comes down due to that. There's actually an extreme cause of that. I think it's called it's like sympathetic childbirth and sympathetic postpartum state, something like that. But yeah, it's where you actually like feel the pain. It's extremely rare, but it is interesting that that
Mhm.
occurs at all.
And even oxytocin itself after a child is born is gonna blunt T in a man, right?
Um, it can, but that being said, I don't think that like the oxytocin that you get from a skin to skin time would blunt testosterone that much.
Mm.
Um,
It's probably
I,
everything, right? You're not sleeping, you're probably stressed
yeah,
out. It's good. I mean, it's great. It's the most beautiful time in the world, but, it's hard. So
yeah, I agree. And some people think that that's a uh, if you if you survive it, because historically a lot of people have sadly not survived childbirth, but if you survive it, then often it does make you healthier in a holistic way in the long term.
mhm. Yeah, that purpose, like you're talking about for sure. I think I told this story on a podcast before, but we have a 14-month-old and he was unexpectedly in the NICU for a life-threatening, unexpected bowel issue after he was born. Um, it was a stressful time to be in the NICU, right? Like we were expected to go right home and all of a sudden we're surgery and TPN and all these things, right? And then we're like vigilant and stressed and et cetera. And like my husband gets up like once the we're not in immediate danger anymore, right? We're like still there, but we're not in immediate danger. And he's like, I gotta go get my blood work drawn for wild health. I'm like, what? Like, he's like, yeah, I got, my quarterly blood work. I'm gonna go get it drawn. I'm like, that's brave. Like, why would you do this right now? We haven't slept in a month. Like, we've
That's
been
great.
eating hospital cafeteria food, like this is not exactly the picture of health. But I tell my patients to get their blood work done no matter what they're going through so we can support them accurately, right? Like, gosh, I didn't wanna be looked
Yes.
at during that time. I was like, "Well, it's probably not gonna look my best," you know?
Yeah, I agree. In fact, sometimes I tell patients it's great to have what I call high tide, low tide blood work. Because if you're looking for damage that the tide does to the beach, then you're not just going to look at low tide.
Yeah. Yeah, it's a great analogy. Nice. So 2 questions on the lifestyle piece that you just brought up. So you mentioned, insulin resistance and metabolic syndrome and the link to SHBG. I just wanna be clear, insulin resistance is gonna directly lower SHBG, right? Like, it's gonna downregulate it.
Mhm.
So,
Yeah,
and
your
then
crash course.
also the
Yeah,
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 go ahead.
crash course in SHBG is primarily made in the liver, and anything that increases area under the curve insulin will decrease it. Anything that binds the androgen receptor in the liver will decrease it. Anything that binds the estradiol alpha receptor in the liver will increase it. So
Interesting.
estrogen can also increase it. That's why SHBG is extremely high in pregnancy, is there's a lot of estrogen in the
And after birth
in the
control,
liver.
I've seen
Yes,
oftentimes.
SHBGs are often very high, especially when you take an anti-androgen birth control. So if you have a synthetic estrogen, ethinyl estradiol, by the way, the most common estrogen in oral contraceptives, which is just synthetic hormone replacement therapy, is 100 times more powerful on that receptor in the liver than bioidentical estradiol.
Wow, I didn't know that. Fascinating. Okay, and then you mentioned sleep. So, great call out for the sleep apnea screen. Completely agree. Sleep apnea should be diagnosed for a number of reasons. Even kind of subclinical or low grade. Like you should at least know what you're dealing with and see if you can improve it, even if someone's not willing to do a CPAP. Um, but is there specific stages? So most of our patients are tracking all this stuff. Everybody's a data nerd around here. Are there specific stages? Is it the deep sleep that you see matter the most, or something specific about the sleep architecture that in your practice you see really move the needle with testosterone?
Yeah, in general, I do see good REM sleep does. And unfortunately, REM sleep is very difficult to track without like home sleep studies. It's like a Lofta or a Somno. There's a whole bunch of fine home sleep studies. But most biometric data tracking devices are great for HRV, resting heart rate, not as great for telling you if you get very high quality or low quality REM. But, you think of REM as your rapid eye movement sleep. You have your most dreams during this time. You have your most nocturnal erections during this time. And it tends to be in the last half of the night. And you also tend to produce most of your testosterone and release it in the last half of the night. So usually your cortisol is increasing as you're about to wake up. Your testosterone is increasing before you're even awake. And that's why one good sign of good natural testosterone production is morning wood, or, that's essentially a nocturnal erection just as you wake up. But if you don't happen to wake up out of REM sleep, you're not as likely to remember your dream or have nocturnal erection, etc. It's just less likely. And if you use an alarm or wake up at very different times depending on the day, then your body doesn't really have that rhythm to wake you up out of REM sleep. Because a normal sleep cycle does include a brief awake period that you usually don't remember right after REM sleep.
Yeah, right on. So are you telling me that the patients that are waking up at 4 a.m. to go to the gym to try to improve their body composition, raise their testosterone, et cetera, might be shortchanging their REM sleep and might be kind of shooting themselves in the foot?
Depends on when they go to bed. I like the 10-3-2-1-0 rule. I took this from Ben Greenfield, but 10 hours, no caffeine; 3 hours and 2 hours, no large meal or vigorous exercise; 1 hour, no bright blue or white light; and then zero variation in the time you go to bed and zero snooze in the morning. So I think if, I usually wake up around that time, but I also go to bed around 8:30. So as long as you have enough kind of like consecutive hours, and there's a whole bunch of nuance. I don't claim to be a sleep expert, but I'm just like uh clinically interested, if that makes sense. So there's biphasic
Totally.
sleep cycles. Before we had this artificial light, maybe we had like an early sleep and a late sleep, and it was natural to be awake halfway through the night. That was the time that people did a lot of things. Um, that they generally wouldn't do during the day. But, and maybe before then, like women's menstrual cycles may have been more aligned with the moon cycle. There's a lot of things that we kind of mostly know, but we'll never know for sure because unfortunately we've just lost that environmental factor.
Yeah, right on. Makes sense. So let's talk about external agents. So before we dive straight into TRT, which most people are going to be familiar with that term, let's talk about maybe some supplements. So, I think there's different categories here. I'm a big fan of repleting known deficiencies. I'm pretty particular about my supplements. We practice precision medicine, right? We're looking at people's genetics, we're looking at their labs, we're doing things in a targeted, measurable way typically. But a lot of these when it comes to testosterone, you know, it's tough to do that with and know what kind of benefit you're getting, right? Like, yes, vitamin D matters and we can measure that, but like the common ones I get asked about, Tongkat Ali, ashwagandha, Fedoja. Like, do you regularly use these sorts of supplements? We've already mentioned that it's not a replacement. This is not a magic bullet. This is not a replacement for eating right, sleeping right, having a spiritual purpose, not being insulin resistant, et cetera, et cetera. But do you see it kind of give that extra 5%? Or, I mean, I don't mean to put a number on it. I'm not quoting literature
Mhm.
here, but, generally speaking, do you see it as a nice adjunct or do you use these often?
Yeah, yeah, I love this topic, and I certainly do because I try to naturally optimize everything that could be holding people back. The way that I describe it is it's like getting into a fraternity or a sorority. If there's one thing blackballing you, you will not get in. Same thing for testosterone. If almost everything is right, but your vitamin D level is 4, which I've seen, then I feel very strongly because if you look at the studies, some people say, well, vitamin D improves testosterone. Well, vitamin D doesn't. And I agree with you 100%. Whatever's insufficient or deficient, you correct that. And that is very likely to improve testosterone levels because vitamin D is a sex hormone, right? It's a sterile hormone. So look at your vitamin D, look at your zinc. Most Americans don't consume enough magnesium in their diet. Look at things like boron. If you're insufficient, replace it. If you're not, don't worry about it. Um, and then past that, you can look at other factors. So, myself and my brothers and friends have certainly used some of these things. And people may remember that I designed a testosterone. I tried to call it a testosterone vitamin because I hate the term testosterone booster. But anyway, I tried to design a testosterone vitamin for Gorilla Mind that my friend Derek owns, and Andrew helped us some as well. But we put in mostly vitamins and nutrients, and some people do benefit from Tongkat. I see the lower your insulin and the lower your DHEA, the more beneficial it is. But it also looks to be a phytoprogestogen, and a phytoandrogen. So it's kind of interesting, like soy is a phytoestrogen, the genestogen and other phytoestrogens in it. So Tongkat's just a very interesting molecule, but not one that everybody should do. Fedoja is kind of similar in that it's been used for hundreds of years in traditional medicine, but most of the studies are not on the agrestis species that is kind of most interesting for LH secretion. But both Tongkat and Fedoja have a downside of increasing liver enzymes. So I never recommend more than 2,000 milligrams a week of either, like spread out, however, during the 7 days. Sustanchi blocks the androgen receptor, so it might be a SARM, like ostarine, if people have heard of that, but we just don't know because we don't have tissue-specific agonist assays. But Sustanchi tubulosa is interesting. It definitely increases testosterone. It definitely blocks the androgen receptor in the pituitary, and it definitely increases LH. But I'd say, I don't want to take Sustanchi for long periods of time, and I don't want to take Tongkat or Fedoja without checking my liver enzymes, and including my alkaline phosphatase, not just ALT, AST, GGT. Because in the studies, at least the preclinical studies, there is some potential downsides there. And then I think you also asked about, was it tribulus?
Ashwagandha, I think.
Oh yeah, so ashwagandha. So I kind of think of like Tongkat as an insulin. If you're insulin resistant, I think Tongkat's more helpful. Or sorry, if you're not insulin resistant, if your insulin's low, Tongkat's more helpful. Ashwagandha is not ashwagandha is a mix of root, stem, and leaves. So people say like, well, ashwagandha doesn't help with cortisol. Ashwagandha does help with cortisol. Ashwagandha is serotonergic, and it really depends on the type. So it's probably like past the scope of the discussion. I don't want to take up too much time, but basically there's a bunch of different types, and Sensoril and KSM 66 tend to have the most data on increasing testosterone some, but generally takes high doses. So, for example, when I was talking to Derek about putting the ashwagandha into the Gorilla Mind Sigma testosterone vitamin, I said, well, I have never seen somebody have a downside like an SSRI type interaction with ashwagandha by taking 300 milligrams or less. But then the Redditors said you have to take at least 650 milligrams if you look at the mouse studies, rodent studies, equivalent in humans, and you have to take 700 milligrams to increase testosterone.
To see a testosterone effect, yeah.
Yeah, but I have also seen people take that dose and they say it felt like I was taking Zoloft, felt horrible, like I was a zombie, less peaks, my sexual health was not good, etc. So unfortunately for all of these testosterone herbals, it's always kind of one of those discussions. Talk to your doctor or dietitian or health coach or somebody that you trust with your health. And there has been upsides, and I've seen some, anecdotally, some crazy increases. And other people probably have too. That's why they're interested in it. But it's not without potential downside.
Yeah. And the majority of the time, I have to tell you, when I'm seeing people on these, they're usually on many of them at the same time and have been for a long time, just randomly without oversight and without labs.
Mhm.
Just thinking like, oh, I want to improve my body composition or I want to improve my T levels. Maybe they got them checked a couple years ago or whatever. And they're on
Uh-huh.
numerous herbals at the same time. I mean, do you typically like trial it and then see what happens after 3 months? Do you pulse dose these? I'm assuming there's nuance to all of these. It's very hard to give a specific answer. But I'm assuming you're not just like starting multiple at a time and continuing them forevermore.
I try to be scientific about it. So, like I said, if someone's like very high cortisol and their sleep is terrible, then I think ashwagandha works a bit better. I like to see what people, not just what testosterone does, but what DHEA sulfate does too. Because Tongkat tends to increase DHEA sulfate, which can be something you might not want with PCOS, but it also might increase SHBG. So it's just very interesting. Yeah, I try to see a cause
Tomcat
and
might.
effect. Yeah. One study showed that Tongkat increased SHBG, but it doesn't appear to be an aromatase inhibitor, which we thought at one point, and it doesn't really appear to be a selective estrogen receptor modulator, which is a SERM. But sorry if I'm kind of using too much jargon, but yeah, basically, I think that a pulse dose and checking labs before and after, even if somebody's doing this on their own, without the oversight of a healthcare provider, as long as they have a decent idea and are using a reasonable dose, staying under 2 grams per week of either Fedoja or Tongkat, um, I think that they can see a response. And at the end of the day, it's kind of like food sensitivity testing. Like, it's, food sensitivity testing is not great. What is the best is still just how you react to different foods over time. And if you feel better with a testosterone boosting supplement, and you're not having any downsides and your labs look normal, then I'm not against someone to continue to take this. I certainly don't think they need to be prescription only.
Yeah, right on. Cool. That was super helpful. And then next subject, which isn't full blown TRT, but kind of more a little more gravity, I would say. What are your thoughts on things like clomidor and clomiphene, or the peptides that affect the growth hormone axis significantly, something like Sermorelin or
Mhm.
similar? Do you have strong thoughts on using these? I have a lot of men, especially men that are in an age where they still want to, definitely preserve fertility, which I know can be done with TRT. But there's definitely some concerns there that a lot of men come in with when they're younger. And they also, I think a lot of men are like, I don't want to start on TRT because I don't know if I have to be on it forever, which is also not true. But they're kind of looked at, I think, like a middle step in some of these scenarios. Like, do you agree with that? Do you use these kind of agents, or what are your thoughts?
Yeah, I use both the SERMs like the clomiphene, enclomiphene, raloxifene, tamoxifen, and I also use the GHRPs, like the growth hormone releasing peptides. I know Thomas DeLauer and I did a video on them, but there's basically the ghrelin agonists and then the GHRH analogs. And I think that they both can be used safely in physiologic ranges. And your ideal candidate for a SERM is someone who has very high estrogen, because SERMs do not boost testosterone. They just block estrogen. So if estrogen is blocking your testosterone, that's the rate limiting step that is occurring right then. And your testosterone would be much higher if estrogen was not blocking the release of LH. So let's say you have a estradiol of sensitive estradiol of 50 picograms per milliliter. You have a LH of 1.6, and you have a total testosterone of 320. Um, Especially if that individual is a higher body fat percentage, I think this is fantastic. Now, some SERMs do carry the risk of potentially increasing risk of CVA or strokes. But and if it increases SHBG, anything that binds the estrogen receptor in the liver, you can actually estimate its DVT risk, like your clot risk, by seeing if the platelets increase and SHBG increases. Because a lot of times the same estradiol alpha receptor in the liver increases both the platelets and the SHBG. But yeah, that being said, I've used enclomiphene many times, temporarily, semi-temporarily. I personally wouldn't want to take it for several years, and I definitely think it is a weird flex for the clinics that say, "I am the number one enclomiphene prescriber in the world." I would not want that. It's like a temporary Band-Aid because if you're going to take it for a really long period of time, testosterone replacement strategies like lymphatically absorbed testosterone, Natesto, even microdose subcutaneous testosterone has more benefits and less downside in the long term.
Hmm.
So
Yeah.
it's good for a couple years. And exactly like you said, usually younger patients, usually wanting to have more imminent fertility. Um, I've talked about like my varicocele and how I've optimized my testosterone on my podcast many times. And there's another video on that coming out soon because obviously I have 3 children. Um, and my oldest my youngest just turned 12 months. So we're just behind you. But yeah, anyways, I was not on enclomiphene for conceiving any of them, not because I think it's unsafe. A lot of my patients have been, but I'm always thinking about theoretical epigenetic risks. Um, and it's just kind of a big question mark. The more I practice medicine, I've delivered a couple hundred babies, I've done prenatal care for a ton of people, and I read these studies about metformin and SSRIs of the dad taking it. And there's some risks and even things like alcohol use paternally. So I just try to be as natural as possible if I'm in a fertility or conception phase. Obviously, not
Yeah.
everybody is able to do that. You have to weigh it. Um, so that I don't love kind of how strongly these molecules block and activate estrogen.
Yeah, sure. That makes sense. Cool. And then let's dive into TRT a little bit. So we don't need to go wild into this subject. I think it's talked about a lot. But if you had some pearls you wanted people to know, we'll just start there. What would they be?
Yeah, you've already mentioned several of them. So one of them is if you start, you can come off. You don't have to be on for a lifetime. I tell people it's a lifetime commitment to thinking about your testosterone. You can come off and regain what you naturally had before, and uh, you should at least continue to check it and try to improve it. But it does not need to be long term. Subcutaneous testosterone does appear to be much better tolerated, and it's the best metabolically. So, one of the big things that people have talked about recently is the Traverse trial. This was the trial about a year and a half ago. I think it was published in New England Journal of Medicine, and it was about 5,000 patients who were assigned to placebo or to androgel, which is a long-acting 24-hour release transdermal or topical testosterone gel. And their levels went from maybe 260 to 400, and they had a little bit less diabetes. They had a little bit less ischemic heart disease related events, slightly more electrical heart disease, it's like slightly more non-fatal arrhythmias, and they had much better like general metabolic health. Their lipids were fine, their blood pressure was fine, but a lot of them were also very sick people. So most of them were actually on like statins, aspirin, and blood pressure meds. And these people were not like replaced up to 900, but they did use a transdermal gel, which is very heavily DHT related. So the main
Mm.
takeaway here is like a lot of people saw this. And by the way, this was the kind of like the straw that broke the camel's back. And now all the commercial testosterones no longer have the black box warning for heart disease, which is great. And I agree with,
Mhm.
but it doesn't mean that you can, replace a compounded testosterone cream. Your DHT goes up to 400, your testosterone goes up to 1500, and then not say, well, this wasn't a risk factor at all for my like electrical
Sure.
heart disease arrhythmia. Um,
Yeah.
that being said, in general, if the upsides weigh the downsides, and probably for most people 50 plus that have like testosterone below 400, 450, the upsides probably do outweigh the downsides. I think it is still our number one anti-aging tool, even over peptides, microdose GLP-1s, et cetera, because it gives you the tools to have a better life. When my testosterone's better, I exercise better, I'm living life in bold colors, I play later in the day with my kids, I'm not so tired in the evening, I'm eating better. So it's a tool to really help those lifestyle interventions work the best.
You're sleeping better, which affects every aspect of maybe not you, but a lot of people
Yep.
with better testosterone levels, which is going to affect every axis of health, right? Um, do you have if you're comfortable sharing, could you guess an average age of when you start TRT for men?
Nationally, I'd assume this is, I'd say the median is probably 60. The average is probably lower than that because a lot of people do start very early for a variety of reasons. The average is probably 50. In my practice, it's probably about the same median, but my average in my practice would be much lower because I have a lot of patients with zebra diseases, which is like in medicine, a zebra disease is not extremely common. Um, so those uh, individuals tend to seek us out. But I'd say the average age that somebody should start at least checking it would be 18, and maybe like if you have children, like maybe even checking testosterone levels through puberty and development as well.
Mm, interesting. Um, I feel like for men, I'm obviously not speaking as a man, so I could be totally off here, but I feel like when testosterone is low, it's like this like stigmatized, shame-inducing scenario for a lot of men, or at least they might feel like it is, or it's talked
Yeah.
about like it is. Um, do you feel like that's true in the men that you work with, even though there's this variation of like what's normal and what's healthy for that male? Like, do you feel like this is something that's talked about, should be talked about?
Yeah, it's a great question. I think most of my patients and many of my patients have said publicly via a variety of ways, "Hey, I go to Gillett Health and this and that." So a lot of my patients and friends are very vocal about this. And I think that's really improved public health and perception. So thank you to all of them that have said that. Not that you have to do that if someone's at Gillette Health, but I feel like it's not really an issue for them. But in the general population, definitely an issue, especially in the older generations. The younger generations are, some of them still feel that way, but most of them do not. But again, it's my bias. People also come up to me in the gym and ask me the best muscle building peptide and where they can get it, and tell me about their testosterone cycle that they're doing. So, which is great. I don't judge people whatsoever for anything, whether it's about their nicotine use or, whatever molecule that someone chooses to do. But yeah, I feel like that's much changed. And 20 or 30 years from now, I feel like it'll just be open discussion, kind of like mental health is, I think, mostly destigmatized at this point as well.
Yeah, right on. Okay, well, let's go through kind of a hypothetical case if you have a couple more minutes. So, this is just a super common scenario I see. So we kind of touched on it earlier, but say a man's in his 30s, pretty young by like a general sense without some kind of central hypogonadism like we talked about previously. It's not a zebra, right? th- this person can produce testosterone adequately, we think, or we have every reason to believe. Um, but maybe they're normal. Maybe the testosterone's 400, something along those lines, but they're not happy with it. How are you gonna treat that patient? Are you gonna, like, start with lifestyle first for a few months, recheck it, and then, consider the supplements? Are you gonna do all these things adjunctively? Let's assume, because this is an average wild health patient, their insulin resistance is taken care of, they don't have sleep apnea, they don't have hypothyroid, like, the basics, kinda the foundational stuff is checked. How do you approach people like this? Because this is such a common scenario that we see. It's probably gonna be the average person listening to this podcast still, if they're still hanging out with us at this point.
Yeah, a great question. So, i- in a case like this person, I would also ask them their goals. So, I believe that I'm a Christian. I believe that we're put here as organic machines. And when you have a car, some people want to take their car in and they want to paint it and put turbochargers on. And to some degree, I think that's reasonable with our organic machines and bodies as well. It probably means we take great care of them. Most people who like cars have like 70-year-old classic cars, and most people do not. So I just want to be a good steward of what God's given me personally. And I think most people that would be at Wild Health would be a very similar way. So if their goal is to, maybe their profession, maybe they're a firefighter or something, and one of their main symptoms is body composition changes, athleticism changes, etc., and they want to continue to provide for their family, I think it is very reasonable to skip to a more aggressive option. Make sure that like whatever they need to take care of in their life with their goal, it is taken care of. Because a lot of people like that are athletes. That's why you see first responders, military, et cetera, have much higher rates of earlier in life HRT because it is a tool that we have been given. And I think that having a good conversation about the risks and benefits to jumping to that a little bit earlier is fine. But that being said, of course, I like to, like, almost regardless of age, I like to naturally optimize as much as is reasonably possible. And I also like to ask them, well, do you plan to have fertility imminently? Do you struggle with um, your skin? Like, did you have a bunch of acne in adolescence? Do you have, talk to them about hair loss. You can talk to them about prostate health, even if they're not in very advanced age, even potentially someone in the 30s looking at their family history. And that way you can kind of put all those things on that scale of upside and downside. And then if the upside and downside of natural optimization versus something that's not full TRT versus TRT, kind of get an idea of where that benefit to detriment ratio is.
Right on. But it's not unheard of for you to start TRT in these ages if the goals align, if the risks are low, all of those things. Like, it can
Correct.
happen, people can go off of it. This is a myth that you have to be on it forever
Yep.
and you can't preserve your fertility and all those
Yep.
things, right?
Yeah,
Yeah,
here's a
nice.
hot take. At a lot of places before the age of 35, you get enclomiphene. After age 35, you get TRT. This is your cookie cutter pill mill places. I feel comfortable enough saying that. And part of the reason why is if you have a very large number of patients under 35 on hormone replacement, then that's certainly kind of a yellow flag, which I guess is okay. Like, I understand regulation. Um, but yeah, I don't think that just for like clinic policy being 35 and under, you only get enclomiphene. I've seen that a lot, unfortunately.
Yeah, you gotta treat the individual person, right? Sweet. Well, this was fascinating. I learned a lot. I appreciate it. Is there anything else that you'd want people to know, some pearls you want them to go, kind of for takeaways from this? If, you wanted to bust any myths or give any take home points, like, feel free.
Yeah, for sure. But yeah, they can feel free to YouTube or Google my name or the Gillette Health Podcast. Any interaction is very helpful. I do post all of the like specific sensitive hormone assays and such on my websites if people are interested. And just keep in mind that if you take those to your primary care, most of the time insurance rejects it because it's a little bit more expensive test. $30 instead of $5. And then, yeah, if people want to learn more specifically about whether it's hormones or peptides, I do try to post all of the like research studies that I go over, and I try to respond to all the comments on the podcast that I do, like this one, and on places like Instagram. So if they find Kyle Gillette MD, I will try to respond to all those.
Awesome. Well, I appreciate you coming on, Kyle. It's been a pleasure getting to know you, and thanks for teaching us all.
Absolutely, my pleasure.
Thanks so much for listening to the Wild Health Podcast. If you want more daily health education, be sure to follow us on Instagram, which is filled with health optimization how-tos, grocery shopping lists, guided breathwork posts, myth debunking, and so much more. You can find us at Wild Health MD on Instagram.